Lenticonus, a deception to refractive surgery. Author Dr. Sonu Goel, Anand Eye Hospital, Jaipur, India. None of the authors have any financial interest in any of the products. So the first patient presented to us was a 22-year-old female with the uncorrected visual acuity of 2.5 meters both eyes and the best corrected 6'9" both eyes. Now this patient had a refractive error of -17.5 with -1.5 cylinder at 70 in the right eye and -18.5 with -1.5 at 170 in the left eye. The intraocular pressures in both the eyes were normal and the dilated fundus examination was absolutely normal. The axial length in the right eye was 21.12 millimeters and the left eye measured 22.33 millimeters. The topography readings: right eye measured 44.25 and 43.25 as against the left eye where the topography reading was 44.25 and 45.75. That means an absolutely normal topography picture. The pachymetry in this patient as shown was 522 microns both the eyes. How do you manage this refractive error? LASIK, PRK or a phakic IOL? But wait, there is something more to come, and this is the dilated slit lamp photography picture which shows that there is an anterior lenticonus both the eyes. So this is the oil droplet sign on the retroillumination under the microscope. The systemic examination done for this patient, there were no signs of hearing loss. The serological examination were within normal limits and the kidney and the urinary examinations were within normal limits. So this patient was managed by a clear lens phacoemulsification with a multifocal IOL implantation in both the eyes. So this patient was taken under topical anesthesia. As you can see here, the oil droplet sign in the center, two side port entry at the 12 and the 6 o'clock position, clear cornea, viscoelastic injection, and then anterior capsulotomy. Note should be made that this is a very elastic capsule and we are finding it difficult to make an opening and initiate the rhexis. This is very typical of an anterior lenticonus. Once the initiation has been done, using a microforceps, a round regular capsulorhexis of 5.5 millimeters can then be achieved in a single throw. See how elastic the lens capsule appears. Clear corneal 2.5 millimeter temporal incision. A good hydrodissection. And simply phacoaspiration of the nucleus by manual aspiration of the cortical matter. A good polishing of both the posterior capsule and the posterior surface of the anterior capsule right up to the zonules or the sulcus. A multifocal IOL of 20.5 diopters is implanted in this patient. Now this is the most important point that we want to highlight. A patient with a refractive error of near around -17 and -18 diopters with normal keratometry readings and normal axial length giving a power of 20.5 diopters could only fit into a lenticonus, and this is what is surprising. A good glow, a multifocal lens being implanted in the bag, viscoelastic being washed, the ports are sealed, and the day one, both the eyes 6 by 6. This is the second patient in our series, a 25-year-old male who presented with a history of progressive decrease in vision over the preceding 5 to 7 years. The visual acuity in the right eye uncorrected was 660 and the best corrected 612. The axial length 22.12 millimeters. The fundus and the pressures were normal. In the left eye, the uncorrected visual acuity was 636. The best corrected visual acuity was 612. The axial length measured 22.43 and the IOP and the fundus examination were absolutely normal. Look, the dilated symptom examination shows both the anterior and the posterior lenticonus. There were no hearing loss. The serological examination were within normal limits, and the kidney function test and the urinary examinations were within normal limits. So this patient was managed by clear lens extraction with a foldable lens implantation. You can see here on retroillumination a clear oil droplet sign is visible. Viscoelastic would then be injected, and note should be made how difficult it is to initiate an inelastic anterior capsule of the rhexis. So multiple strokes make us initiate, and then with the help of a microrhexis forceps the capsule can be grasped and a round regular rhexis can then be achieved. A 2.4 millimeter clear corneal temporal incision followed by hydrodissection. And a phacoaspiration of the lens matter can then be done. A good polishing of the posterior capsule followed by the injection of a multifocal IOL. This is the first day post-op picture where the patient has a good reasonable vision. Thank you.